Imagine this. You just finished a 40-minute complex patient visit. They had multiple comorbidities, they had medication changes, new labs that you ordered, and a care plan. And you coded appropriately. You thought you were confident in your documentation, but a few weeks later, you got a response saying that they denied it due to lack of medical necessity. Your team had sent in documentation. You double-check everything. So what went wrong? Now, most of the time, it's not about what you did, but it's either about how you told the story, what you documented in your note, or the ICD-10s were too vague. And so this week, we're going to talk all about ICD-10s. So we're going to talk a little bit about what ICD-10s do, what they don't. Very excited to share some of these things with you that our coders see, that our team sees and deals with on a daily basis. So welcome back to this week's episode with the NotRevMD podcast. As you know, we are a full service medical billing and coding team. If you haven't checked us out, head on over to notrevmd.com. We've got a book, we've got a billing course that is for no cost at this time, and some other resources there for you to check out. So this week, we're going to, again, really just focus on strengthening the idea behind what you put with your CPTs. So thanks so much for joining. All right. So first, let's talk about what ICD-10 codes actually do. We're going to start with the basics on this because I think this is where it's easy to get tripped up, right? We all know CPT codes, they tell the payer what you did. And ICD-10 codes explain why you did it. Now, of course, together, they're going to basically allow you to get paid, kind of the what and the why. Now, here's the thing. We know that payers aren't reading your notes. Now, sometimes they will request medical records and we'll send those in, and then they're making some determinations on whether the modifier 25 medical necessity, whether the CPT medical necessity. But most of the time, it's your ICD-10 codes are translating that clinical decision making basically into the language that their system understands. And so if your CPT code is like the prescription, your ICD-10 code is like the diagnosis that justifies the writing of the prescription, right? So to speak. Now, without the justification, right, the system's not going to connect the dots and you're not going to get paid. So ICD-10s are really that they do three things kind of behind the scene, right? So from a CPT perspective, they're driving medical necessity. So they prove that the service was reasonable and necessary for the patient's condition. They are also the evidence of the patient's acuity. So vague coding looks like vague care, right? So you want to make sure that you have everything there that kind of speaks to the acuity or the complexity of the patient. And these really are also what feed into payer data models that impact risk adjustment, prior authorizations, and contract renewals. So they keep all this data behind the scenes. I think the ICD-10s are also an important part of how they use our data as a whole in order to impact payer policies. So it's super duper important to choose precise, specific ICD-10 codes. Really, you're not only helping your billing team, you're not only helping your team get paid, but you're also really just documenting appropriately so that the payers know that what you're doing is defensible. Now, there have been some misconceptions around ICD-10s within the physician community and even within our own teams, not our billing teams, but our practices that we serve. So ICD-10s are obviously very powerful, right? So they are telling the story. They've got to prove medical necessity. What they don't do is determine your payer amount, meaning if you have CPTs that you're billing, and then you have a sequence of ICD-10 codes. Rearranging those is important in order to not get denied. It is important to have, the one that spent the most time on or the highest acuity, but that's really in order to make sure that the CPT doesn't get denied. The ICD-10 code is never going to change the payer amount, meaning if you put a more specific or higher level ICD-10 code, that's not going to take the payment of that CPT from $200 to $300, that's just going to make sure that it was actually paid. And so we had a question come to us recently about if the ICD-10s aren't moved around, we'll get paid less. And that's not accurate. It's not going to change your fee schedule amount. You're going to get paid per the fee schedule as long as the CPT code is approved. It's not denied. Now, you can have denials for inappropriate sequencing of ICD-10s or inappropriate ICD-10 codes, or you can have requests for medical records that then you submit and then they make a judgment on downcoding for a specific CPT. But the ICD-10 itself does not change your fee schedule. Another thing that's really important is regardless of what ICD-10 codes you put in there, the documentation still has to be the best, most defensible place for a medical review or an audit to be able to be judged upon. So you can put all the complex ICD-10s and most specific ICD-10s that you want, but if the medical documentation behind it doesn't support those ICD-10s, doesn't share the story of the ICD-10s you put, then the ICD-10s really are useless at that point if an audit happens or if medical records are requested. So if the note says shortness of breath, but you code COPD exacerbation, but you don't talk about the COPD and the exacerbation within the note, then that's not going to help you if those records are reviewed. Now, of course, ICD-10s don't ever guarantee reimbursement, right? So if you have a CPT code and you put an ICD-10 code, but it doesn't meet medical necessity, and that's accurate, per your documentation, then the ICD-10 code may not meet medical necessity for the CPT. Now, the great news is that CMS does publish a lot of this online so that you can see what ICD-10 codes help meet medical necessity by certain CPTs. Obviously, the private payers usually aren't as great and transparent as that. Many of them do follow a lot of the Medicare rules, but you can at least start with Medicare and understand those medical necessity rules that CMS puts in place. So just really want to make sure everybody understands ICD-10 codes do not control the amount of your payment, but they absolutely control whether or not you get denied or the payment happens at all. Kind of think of them as the gatekeepers, right? So if the payer system can't see the clinical logic that connects your ICD-10 codes to your CPTs, then that claim won't pass that first line of defense, and they may ask for medical records or more information or just deny it outright. All right, now let's talk about how to use ICD-10s to maximize reimbursement so that you can make sure that you've got these strategies in your back pocket, that you share these with your team. Obviously, the first is coding to the highest level of specificity. So unspecified ICD-10 codes should be your last resort, not your default. So if the chart says pneumonia due to Klebsiella, then you're going to want to use J15.0, not J18.9. If the patient has type 2 diabetes with neuropathy, then you'll want to use that code E11.21, not E11.9. And pairs do look at these codes that tell a clear clinical story. Specificity really helps you claim that complexity. It's obviously not how coding works. It's just not how E&M coding works, but it does support what you're telling the story within your documentation. So specificity kind of equals credibility, and it can reduce medical necessity denials. Now, sequencing. So your first diagnosis should reflect the primary reason for the encounter or the procedure. Subsequent codes are important, right? They show contributing or secondary conditions. And so you'll want to put all of that, and you do want to have them sequenced appropriately. But again, if you're not sequencing appropriately, but the claims are still getting paid and moving forward, I wouldn't stress, looking back, but I would try and, sequence them moving forward. Our team will, move them around if they're absolutely confident in that. Remember, most billing teams have billers who are submitting claims and coders who code claims. So you just want to really make sure that you're understanding what level of service. Most billing teams don't also code unless that's been clearly delineated as an expectation and need from the practice. So typically, if there are coding errors or coding denials, those are put and saved for a coder or brought back to the practice because you'd have to read every single note in order to code for those, which is a different level of service, different level of individual. Now, for many of our surgical practices, we do the coding, and that's, requested and kind of part of the contract. So you just really want to be sure whose responsibility is what. And at the end of the day, the physician is ultimately responsible for the coding. So you want to make sure that you know who's doing what within your practice. All right. So you do want to also rule out diagnosis in the outpatient setting. So what I mean by this is you can't code for something that you just think it is. You code for what you know it is. So if a patient presents with chest pain and you're ruling out an MI, then you're going to give the diagnosis of chest pain, right? You're not going to put the MI down as a diagnosis until that's been confirmed. So this just also is a good rule of thumb, and it keeps your coding compliant and just protects you from audit exposure. Now, you'll want to make sure that you're linking the diagnosis to the correct CPTs, right? Because oftentimes you may be submitting multiple CPTs, and maybe they're all the same ICD-10s, but you'll just want to make sure that you're linking the diagnosis to the correct CPTs. Now, what will happen if you do connect the wrong diagnosis and CPT code? Sometimes you could get a denial. Sometimes it will still meet medical necessity and you'll get paid, but just want to make sure that, those things are caught, especially in denial reviews. If there are coding denial reviews, that's typically something that our coding team would be looking at when they are seeing those denials. Really important, this is, I think, underrated. Really want to make sure that your templates and that your outdated codes in your PM software are updated on an annual basis. And this should be kind of part of your annual workflow with your vendor, with your EMR or PM software, just to make sure that those CPT codes are accurate. The new ones have been updated. The old ones or removed ones have been removed from any favorite lists or templates so that you're using active, complete codes. So very important to have this be part of your process. Now, when you apply these steps consistently, you can have good success with your ICD-10s. I would say the majority of our practices do not have coding denials. We have some practices that may have incomplete documentation. So then the insurance companies will ask for medical records and they'll downcode those visits. And so we're constantly reminding folks got to document the full story. So even if your ICD-10 codes tell the perfect story, if your documentation doesn't, when those records get asked for medical necessity, it can be a problem and they will downcode. And then it just puts your practice at risk for future audits and future downcoding without even asking for the medical records, which is not where any of us want to be. All right, so this week we talked briefly about what ICD-10s really do, right? They're telling that story, why that makes your care medically necessary. Now, of course, what they don't do, right? They're not changing your pay rate or they're not changing how much you get paid when a claim is paid. Very, very important to fix weak documentation. We're going to talk about that with our guest here coming up, who really helps practices improve their documentation when it comes to E&M coding so that you have what you need in order to get paid for what you did. Always, always remember that ICD-10s can strengthen the medical necessity. Make sure that you're not using unspecified unless you absolutely have to. Make sure you're only using ICD-10s when you know a diagnosis has been confirmed, right? It's not where you list your differential. And this will help reduce denials, help reduce rejections, and hopefully put you at a lower risk for claims who may need auditing. So remember, these are the language the payers speak. So really, really important to get this language right. All right. Hope you guys enjoyed our podcast this week. Again, check us out here in a couple days. We are going to be having a guest on who's going to talk really about how her and her team have helped educate different practices and make sure that coding documentation meets the level of E&M coding needs and that practices can make sure that they're not worried about undercoding and really documenting so they're getting paid for what they're doing. All right. As always, if you know another physician or other practices or even hospitals, facilities who are learning this and trying to figure this out, share our podcast. It would mean the world to us. And also leave us a review wherever you're listening to this podcast. All right. Thanks so much. You guys have a good week.